Buenos días. Continuando con el programa de hoy, a nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, y chairman del World Congress of Neurosurgery UNESCO ASPNet, Walter E. Dandy, in honor of Professor Yaşargil, a quien agradecemos por la organización de este magno evento, así como a la doctora Deyanira Capi Casillas, chairman del capítulo ASPN, al doctor Salim Abdul Rauf, chairman de Walter E. Dandy Neurosurgical Society, al Dr. Babak Kateb, Chairman de la Society for Brain Mapping and Therapeutics y Brain Mapping Foundation, todos ellos vice-chairmans del comité organizador, y al Dr. Parmenides Guadarrama Ortiz, Chairman del Centro Especializado de Neurocirugía y Neurociencias México. Es para mí un honor presentar la siguiente ponencia a cargo del Dr. Denis Danut, miembro de la Asociación Rumana de Neurociencias, estudiante de la Universidad de Medicina y Farmacia Carol Dávila de Bucarest, Rumania.
Yes. Good afternoon or morning, depending on where you're listening from. I am Dr. Sebastian Dobrescu, and it is my pleasure to open today's presentations. Before we start, I want to welcome you to the third week of the World Congress of Neurosurgery, UNESCO Walter E. Dandy Society in honor of Professor Gazi Yaşargil. On behalf of the Ambassador of UNESCO ASPNet, Jorge Herrera Ramos, President of the World Congress, whom we thank for organizing this event, as well as the Presidents, Dr. Deyanira Capi, President of ASPN Chapter, Dr. Salim Abdul Rauf, President of Walter E. Dandy Neurosurgical Society, Dr. Babak Kateb, President of the Society for Brain Mapping Therapeutics, Brain Mapping Foundation, Honorary Chairman of the Committee, Professor Nasser Argandur, Professor Marcus Rota, and Dr. Parmenides Guadarrama Ortiz, Director of the Specialized Center for Neurosurgery and Neurosciences of Mexico. It is an honor to present today's mediator, Dr. Cristina Sari.
Thank you, Dr. Sebastian Dobrescu. It is an honor for me to be a mediator for today's presentation. I want to thank all the people involved in the organization of this Congress, as it is because of them that we get to have such an amazing experience. I had the pleasure to introduce today Dr. Denis Danut. He's part of the Romanian Association of Neuroscience and a student at Carol Dávila University of Medicine and Pharmacy. Presenting today the topic of comatose state, assessment, and outcome. Welcome, Dr. Denis Danut.
Thank you very much, Dr. Cristina Sari. I will start my presentation. I hope you can see my presentation.
Yes.
Okay, thank you. I would like to take a moment to say that I feel very honored and grateful to be here today, and I want to thank all the coordinators who have organized this Congress, especially Dr. Jorge Herrera Ramos, Dr. Salim Abdul Rauf, and Dr. Babak Kateb, and to have a chance to speak at this Congress about the comatose state. As we speak about comatose states, there is always involved the consciousness of a patient. But what is exactly the consciousness we talk about? It is defined as a state of being aware of physical events or mental concepts. This means that conscious patients are aware, awake, and responsive to their environment. It has been described as a degree of awareness and arousal. So a manifestation of an altered consciousness implies a brain dysfunction. The sleep, though, is an active state which we can see on the EEG, and through a stimulus, a person's wake up. So it is a reversible state of unconsciousness. In order to gain this conscious state, there is a requirement of an intact cerebral cortex, an ascending reticular activating system, and an intact and good projections between the cerebral cortex and the iris. The ascending reticular activating system theory proposed that neurons in the upper brainstem reticular formation project for brain targets that promotes wakefulness. Most neurons at the pontomesencephalic junction that participate in these pathways are located in monoaminergic and cholinergic cell groups. The ascending arousal system largely originates from a series of well-defined cell groups with identified neurotransmitters. This pathway has two major branches. The first branch is an ascending pathway to the thalamus that activates the thalamic relay neurons that are crucial for transmissions of information to the cerebral cortex. The major source of upper brainstem input to the thalamic relay nuclei, as well as to the reticular nucleus of the thalamus, is a pair of acetylcholine producing cell groups, the penduculopontine and laterodorsal tegmental nuclei. The neurons of these two nuclei fire most rapidly during wakefulness and rapid eye movement sleep, which is the stage accompanied by cortical activation, loss of muscle tone in the body, and active dreams. These cells are much less active during non-REM sleep, when cortical activity is low. Their input to the reticular nucleus is crucial, as it sits between the thalamic relay nuclei and the cerebral cortex, acting as a gating mechanism that can block transmissions between the thalamus and cerebral cortex, which is important for wakefulness. So in order to have a good projection between the aras and both cerebral hemispheres, both need to be, of course, in a healthy state, which include a healthy central nervous system with no infections, an adequate blood flow, a normal body temperature, a normal intracranial pressure, substrates which are needed for energy production, and non-abnormal metabolic toxins or wastes in the cerebral hemispheres and in the aras. There is somehow always a way of losing consciousness. It could be either affected the function of the aras or a high enough affection on both cerebral hemispheres, for example, by a disease. As we talked about what consciousness is, there are different levels of consciousness defined by how a person responds to different stimuli from the environment. To obtain this information, there are a variety of tests we can use. We need to do an assessment of factors to define an altered consciousness, which include the respiratory rate, the heart rate, temperature, blood pressure, and oxygen saturation of the blood. The Glasgow Coma Scale is also a useful test in which we can test rapidly the verbal response, the motor response, and the eye-opening response, in which is included the pupil size and their responses to light, which also play an important role for a clinical assessment. An altered level of consciousness can often change from one stage to another rapidly. So a prompt diagnosis and the proper treatment are required. The conscious state involves, like I said before, awareness and arousal. A patient in a conscious state should be able to state their name, date, and location. And as I said before, although a human is not fully aware during a normal sleep stage, it is considered a normal level of consciousness because a person can wake up easily and state the information mentioned above. If a person cannot respond to questions and state the information of name, time, and location in a quick and prompt manner, the person is considered then as confused. So confusion describes disorientation, which makes it more difficult to provide, for example, the medical history of the patient or to participate in a medical examination. Causes could include depression, fatigue, fever, intoxication, medication, and so on. The delirious state, however, is a state of an acute confusional state and shows a variety of disturbances in attention, cognition, and consciousness. Some delirious patients may also show sign of hyperactivity or hypoactivity, delusions, hallucinations, and emotional disturbances, although it is not required for a diagnosis of delirium. Somnolence describes an excessive drowsiness and a response to stimuli with incoherent mumbles or disorganized body movements accompanied by reduced alertness and awareness. A somnolent person often needs a gentle touch or a verbal stimulation in order to initiate a response. An obtundation typically occurs as a result of trauma or medical condition, where the patient shows a decreased interest in their environment, slowed response to stimuli, and sleepiness. In order to maintain attention, a repeated stimulation is needed. A stuporous patient has a lack of mental function and are almost entirely unresponsive, although they respond only to vigorous stimuli like pain. Patients in a stuporous state are stiff or more precisely rigid and quite mute. It appears that they are conscious when their eyes are open and look at objects in their surroundings, and if not stimulated, they appear to be more in a sleepy state. But during a comatose state, there is no response at all to different stimuli. Patients may have no gag or corneal reflex, and some patients have no pupillary response to light stimulus, but I will explain this later. There are a variety of causes which can lead to an unconscious state, like you can see here, an infectious disease, for example, a protozoan infection, a bacterial meningitis, or a viral encephalitis. Or it can have an inflammatory cause, like a multiple sclerosis or a collagen vascular disorder. But there are other structural causes as well. It could be a trauma, like a concussion or an intracerebral hematoma, a focal infection or a vascular disease like a damage of the carotid at the level of the neck. There could be also involved a cerebral hemorrhage or infarction, for example, an aneurysm or subarachnoid hemorrhage. Not only traumatic events or infectious disease are the cause for an unconscious state. Intoxication and nutrition plays also an important role, which can cause unconsciousness. A simple metabolic disorder like a hypoglycemia or endocrinological disorders can lead to a stage of unconsciousness. Furthermore, an hypoxic ischemic encephalopathy can occur if the brain doesn't receive a proper amount of oxygen or an adequate blood flow for a period of time, like, for example, a cardiac or pulmonary failure, strangulation, shock, or a carbon monoxide poisoning. As you can see here, the level of consciousness can be also altered by deficiency, like a vitamin B12 deficiency or various poisons. From industrial agents to illegal drugs to alcohol, heavy metals, or prescribed medication, there is a huge range. As you saw in the last 3 slides of my presentation, we can now say that there is a huge range in which a coma could occur, but these are only examples and not by far all of the causes. A coma is a prolonged state of unconsciousness. A coma occurs when a part of the brain is damaged, either temporarily or permanently. This damage results in unconsciousness, an inability to awake, and unresponsiveness to stimuli such as pain, sound, and light. Comas have a number of potential causes. These range from injury or illness to stroke to tumors to alcohol and drug abuse. A person who is in a coma is alive, but is unable to move at will. they can't think, speak, or respond to their environment. Important functions such as breathing and blood circulation remain intact. A coma is a medical emergency. Healthcare providers need to work quickly to preserve brain life and function. They also need to keep the patient healthy during the course of his or her coma. A coma may be challenging to diagnose and treat. It usually doesn't last for more than 4 weeks, and recovery occurs gradually. Some patients, however, have remained in comas for years or even decades. Comas are caused by damage to the brain, specifically the diffuse bilateral cerebral hemisphere cortexer, the reticular activating system. As I said, this area of the brain controls arousal and awareness. Damage here can result from many potential factors. Like I said before, a traumatic brain injury caused by a traffic accidents or violent fights, a stroke, or overdosing on drugs or alcohol. Treatment for a coma depends on the cause. People close to the comatose patient should give doctors as much information as possible to help the doctors determine the cause of a coma. Prompt medical attention is vital to treat potentially reversible conditions. For example, if there is an infection that's affecting the brain, antibiotics may be needed. Glucose may be required in the event of a diabetic shock. Surgery may also be necessary to relieve the pressure on the brain due to swelling or to remove a tumor. Certain drugs may also help relieve the swelling. Medication may also be given to stop seizures if necessary. So in general, treatment for a coma is supportive. People in comas are looked after in an intensive care unit and may often require full life support until their situation improves. The prognosis for a coma varies with each situation. The chances of a person's recovery depend on the cause of the coma, whether the problem can be corrected, and the duration of the coma. If the problem can be resolved, the person can often return to their original level of functioning. Sometimes, though, if the brain damage is severe, a person may be permanently disabled or never regain consciousness again. Comas that result from drug poisoning have a high rate of recovery if prompt medical attention is received. Comas that result from a head injury tend to have a higher rate of recovery than comas related to lack of oxygen. It can be very difficult to predict recovery when a person is in a coma. Every person is different, and it is best to consult with your doctor. As we would expect, the longer a person is in a coma, the worse the prognosis gets. Even so, many patients can wake up after many weeks in a coma. However, they may have significant disabilities. Focal neurologic signs, also known as focal neurological deficits or focal central nervous system signs, are impairments of nerve, spinal cord, or brain function that affects a specific region of the body. For example, weakness in the left arm, the right leg, paresis, or plagia. Focal neurological deficits may be caused by a variety of medical conditions such as head trauma, tumors, or stroke, or by various diseases such as meningitis or encephalitis, or as a side effect of certain medications, such as those used in anesthesia. Not only focal signs, but also signs of meningeal irritation which are non-specific reactions that may occur in a patient with meningeal irritation. Meningism is defined as signs of meningeal irritation occurring without other features of meningitis or non-inflammatory meningeal involvement. For example, a patient with high-grade fever unrelated to a central nervous system disorder. Causes can include infectious meningitis, it could be bacterial or viral, subarachnoid hemorrhage, neoplasms of the brain and meninges, extensive stroke affecting an area adjacent to the spaces with cerebrospinal fluid. There is also a type of coma which involves neither focal signs nor meningeal irritation like the hypoxic ischemia, where there is not enough blood supply and oxygen supply to the brain, like a cardiac arrest or a shock or pulmonary failure. When a coma occurs, a rapid clinical assessment and a proper treatment is needed. It is important to secure the airways through intubation if the Glasgow Coma Scale is under 8, on which ventilation and oxygenation is applied. It is needed to establish an IV access and take some samples, and the blood glucose can be done by strip testing. A cerebral herniation identification, or ICP raised, could include absent Dolzi movements, abnormal pupil size, and reaction abnormal to or posture, hypertension with bradycardia, and so on. An acid-base imbalance needs to be corrected if that is the case. If temperature shows signs of fever or hypothermia, then it needs to be treated. And we need to give antidotes, for example, naloxone for opiate overdose if needed. We need to stop seizures, and through appropriate antibiotic or antiviral therapy, we can treat an infection if that's the case. In 1994, the New England Journal of Medicine published the consensus reports of a task force that had been charged with determining the clinical criteria for diagnosing the vegetative state. The clinical criteria are no evidence of awareness of self or environment, no interaction with others, no evidence of sustained, reproducible, purposeful, or voluntary behavioral responses to visual, auditory, tactile, or noxious stimuli, no evidence of language comprehension or expression, return of sleep-wake cycles, arousal, even smiling, frowning, or yawning, sufficient hypothalamic and brainstem autonomic functions to survive if given medical or nursing care, bowel and bladder incontinence, variably preserved cranial nerve, and spinal reflexes. The usual investigations done during an evaluation of the vegetative state are an EEG, brain imaging such as an MRI or CT, and perhaps PET scanning. Most important, however, in the evaluation is the patient's history and the physical exam by a neurologist. The vegetative state is a chronic condition that preserves the ability to maintain blood pressure, respiration, and cardiac function, but not cognitive functions. Hypothalamic and medullary brainstem function remain intact to support cardiorespiratory and autonomic functions and are sufficient for survival if medical and nursing care is adequate. The cortex is severely damaged, which will eliminate cognitive functions, but the reticular activating system remains functional, making wakefulness possible. Midbrain or pontine reflexes may or may not be present. Patients have no awareness of self and interact with the environment only via reflexes. Seizure activity may be present but not be clinical evident. Traditionally, a vegetative state that lasts more than 1 month is considered to be a persistent vegetative state. However, a diagnosis of persistent vegetative state does not imply permanent disability, because in very rare cases, for example, after a traumatic brain injury, patients can improve, reaching a minimal conscious state or a higher level of consciousness. The most common causes of a vegetative state are traumatic brain injury and diffuse cerebral hypoxia. However, any disorder that results in brain damage can cause a vegetative state. Typically, a vegetative state occurs because the function of the brainstem and diencephalon resumes after coma, but cortical function does not. In the minimally conscious state, unlike the vegetative state, there is evidence that patients are aware of themselves and/or their environment. Patients also tend to improve, becoming more conscious, but improvement is limited. This state may be the first indication of brain damage or may follow a vegetative state as people recover some function. Patients can transition between the vegetative state and the minimal conscious state, sometimes for years after the original brain damage. Patients cannot react to visual threat and cannot follow commands. The limbs may move, but the only purposeful motor responses that occur are primitive. For example, grasping an object that contacts the hand. Pain usually elicits a motor response, but not purposeful avoidance. Patients have fecal and urinary incontinence. Cranial nerve and spinal reflexes are typically preserved. Rarely, brain activity detected by functional MRI or EEG indicates a response to questions and comments, even though there is no behavioral response. The extent of patients' actual awareness is not yet known. In most patients who have such brain activity, the vegetative state resulted from traumatic brain injury, not hypoxic encephalopathy. Here you can see a quote I found which describes quite good the minimal conscious state. It says, "The minimal conscious state was first described in 2002 as a condition of severely altered unconsciousness, in which minimal but definite behavioral evidence of environmental awareness is demonstrated." But this also raises the question on what is the exact difference between the vegetative state and the minimal conscious state. Patients may demonstrate attention and intention, purposefully track, and even communicate. The minimal conscious state should only be diagnosed when there is clearly discernible evidence of one or more of the following behaviors: simple command following, any gestural or verbal yes/no responses, intelligibly verbalization or movements, movements or behaviors that are contingently responsive to environmental stimuli. Minimally conscious state behaviors contrast the wakeful unresponsiveness of vegetative states in which there is no awareness of self, others, or the environment. Nonetheless, these two brain states can be conflated because of the episodic and intermittent failure of behavioral responsiveness in minimal conscious state. Certain behaviors distinguishes the minimal conscious state from the vegetative state. Visual fixation, smooth pursuit tracking, and emotional or motor behaviors contingent on specific stimuli may be associated with lower levels of diagnostic certainty than inconsistent comment following or object manipulation. In brain death, there is irreversible loss of function of both cerebrum and brainstem, leading to the inevitable failure of other vital organs, including the heart. Brain death, effectively is death of the entire body and can be diagnosed while the heart is still beating. Although any experienced physician can make this declaration, it is usually relegated to a neurologist or neurosurgeon. Brain death may be the consequence of hemorrhage from trauma, uncontrolled hypertension, or a ruptured berry aneurysm. Other causes include large or multiple ischemic infarctions, meningoencephalitis, and anoxia from cardiac arrest. Extensive areas of the brain become ischemic with shifting of herniation of vital areas due to edema. In the case of cerebral anoxia after cardiac arrest, the gross brain is fragile. It appears swollen and hardens poorly and fixative. In order to declare brain death, the apparent cause should be known, such as traumatic head injury or a witness cardiopulmonary arrest, and must be of sufficient severity to account for the irreversible coma. A brain CT scan may help show extensive hemorrhage, edema, or ischemic changes. If the cause of coma is unknown, the patient requires continued life support measures while longer periods of observation and further diagnostic testing are undertaken. In brain death, there is no neurological improvement despite adequate treatment of any reversible causes of coma, such as drug intoxication or hypothermia. Severe metabolic or endocrine abnormalities should be corrected as well, and the effect of anesthetics and neuromuscular blocking drugs should be allowed to dissipate if coma occurs in the post-operative period. When the etiology of coma is known and no reversible causes require treatment, the generally accepted observation period is 6 hours. The brains of infants or children tend to withstand anoxia better than the adult brain and occasionally undergo remarkable recovery. For this reason, longer observation periods are suggested for those 7 days to 2 months old. The observation periods are 48 hours, 2 months to 1 year old, 24 hours, and over 1 year old, the observation period is 12 to 24 hours. The bedside neurological examination should not show any hint or suggestion of cerebral function in a comatose patient unresponsive to painful stimuli. Thus, there should be no decorticate or decerebrate posturing, seizures, swallowing, or vocalizations. However, some spinal cord-mediated movements may still persist, such as muscle stretch reflexes. I will show you in a minute the brainstem reflexes tests you need in order to declare brain death. Apnea can be verified by specific testing methods if the patient remains hemodynamically stable. The ventilated patient is given 100% oxygen for 10 minutes to create an oxygen reserve in the lungs, and the baseline arterial blood gas is tested. The ventilator is then discontinued while 100% oxygen is still supplied through the tubing. If no respiratory movements occur after 10 minutes, another arterial blood gas is tested. Apnea is confirmed if no breathing is observed despite reaching a carbon dioxide pressure of 60 millimeters of mercury or greater, or perhaps a carbon dioxide pressure of 20 millimeters of mercury above baseline value. The mechanical ventilator is restarted at the end of the test or earlier if hypotension or arrhythmias occur during the apnea test. With the Glasgow Coma Scale and its test, a rapid assessment during an emergency is possible. With this, we can test three main points: the eye-opening response, the verbal response, and the motor response. As you can see in the table I have here, is a range between eyes open spontaneously to no eye opening, and from oriented to no verbal response, and from obeys commands for movement to no motor response. As soon as the responses are tested, there are points given which we will add up, and the total amount is 15, which is the best response. But if the added points are 8 or less, we have a comatose patient. If the total of these points is 3, then the patient is totally unresponsive. As you can see here, we can test some reflexes in order to see the brainstem function. For example, we have the papillary light reflex, in which we will test the cranial nerves 2, 3, and the midbrain. If there is no response to light and we can see fairly dilated mid-position pupils, it is associated with brain death. We can also test the corneal reflex, in which we will test the cranial nerves 3, 5, and 7, and the pons. If the eyelid closes through touch or even may rotate upwards, it says that the brainstem function is intact. If we don't have no response at all, it is associated with brain death. We can also test the oculovestibular reflex, in which we will test the cranial nerves 3, 4, 6, and 8, the pons, and the midbrain. If there is no eye movement involved, then it is associated with brain death. We can also test the oculocephalic reflex, in which we will test the cranial nerves 3, 6, 8, the midbrains, and the pons. If the eyes are staying fixed as if they would maintaining eye contact, then everything is good. But if the eyes are moving with the head movement, it is associated with brain death. Through the test of the gag and cough reflex, we can test the cranial nerves 9, 10, and the medulla. If there is an absence of cough and gag reflex, it is associated with brain death. We can also see through the posturing the motor function. There are two posturings, one the decorticate posturing and the decerebrate posturing, which I will show you in a minute. Here you can see the decorticate posturing, in which we can see a flexion of the upper limbs and the extensions of lower limbs. If we see that, there may be involved the cerebral cortex and the brainstem. If there is, however, the decerebrate posturing with a stiff extension and of the upper and lower limb, it may indicate damage of cortical and the brainstem. I also found two clinical cases which I found very interesting. In the first clinical case, the patient JV experienced a serious TBI due to a car accident at the age of 18 years. At the accident site, he presented a Glasgow Coma Scale score of 4 with wide fixed pupils and a decerebrate posturing of all 4 extremities. The patient was hospitalized at the intensive care unit Universitätsklinikum Würzburg in Germany. CT scans revealed a diffuse brain edema and subdural bleeding with midline shift. An emergency decompression craniotomy was performed to reduce intracranial pressure by removing parts of the cranium. After operation, JV still displayed fixed pupils, no corneal reflex, and no motor response to pain. He further displayed seizures affecting the left side of his face. The family was told that brain damage was devastating and that survival was very unlikely, but the family decided to continue life support. JV remained in the ICU for 12 days, after which he was transferred to a neurological rehabilitation facility in Germany. At admission, he displayed coma, an acute subdural hematoma on the right side, brain swelling, artificial respiration, abnormal pupillary functions, severe spastic tetraplegia, a tracheal cannula, percutaneous gastrostomy, and a decerebrate posture of all extremities. In picture A, we can see a computed tomography from the day of the accident showing acute right side hematoma with a midline shift. Rehabilitation occurs with all positive and negative predictors. I'm sorry. During the first month in rehabilitation, the patient was still on ventilation and autonomically unstable with sweating, tachycardia, and hypertension. No change in mental status was observed. In the second month, the EEG showed severe slowing with delta theta dominance. MRI displayed a right frontal subdural hematoma and an asymmetric right dominant ventricle system enlargement without midline displacement, as well as a parenchyma lesion with gliosis in temporal regions and in the white matter surrounding the posterior horn of the lateral ventricle. Still, by the end of the second month, JV could be weaned from ventilation, although there was no change in cognitive functions. By the third month, the patient reached the status of minimal conscious state. However, there were no vocalizations other than grounding to painful stimulation. No communication channel and no comment following could be established. After 4 months, a newly conducted MRI revealed considerably brain atrophy, multiple parenchymal lesions, diffuse shear lesions, but no periventricular transudation of cerebrospinal fluid. 5 months after the event, the cranium reimplantation was scheduled. After the operation, various complications occurred, including an epidural hematoma, which required a new surgery. No clinical improvement was apparent. After 7 months, JV began with situation-independent screaming. This lasted for over 4 weeks. He screamed and moaned during his wake phases, which did not change with painkillers or other medication efforts. 8 months after the event, JV began to close his eyes on command, clinically indicating progress to minimal conscious state. And 9 months after the event, the patient established a communication channel, first via eye blink and shortly thereafter also via nods and head shaking. Communication is described as increasingly adequate, which implies that the patient improved beyond the minimal conscious state. At this point, after 9 months of intensive treatment, he was sent home from early rehabilitation. Now, JV is able to walk independently using stairs and even ride his bicycle again. He has reached independence in all activities of daily living. His memory functions are still reduced, but he has learned to cope. His speech is slow, but his vocabulary and intonation are perfectly normal. He has communicated with the researchers personally via telephone, and now he is employed and lives close by, but independently from his parents. I also found the second clinical case, which I found very interesting. You will see now why. A 20-year-old Caucasian male was brought to the emergency department via ambulance after being found unresponsive. The patient lived with 3 roommates and worked full-time in his father's window tinting business. The previous evening, he had been out with friends where he had a few beers and a little weed, as the friend says. The patient returned home with his friends at about 4 a.m. At home, he took a tub of ice cream from the freezer and walked out of the house. Shortly after, his friends went to his parked car where they found him asleep at the wheel with the ignition off. They attempted to rouse him without success. He was carried into the house and left sleeping on the living room floor. After several hours, he remained unresponsive. Later in the morning, his girlfriend arrived and could not wake him up. She telephoned the patient's father, who called then 911. In the ambulance, the patient's heart rate was 72 till 90 beats per minute. Blood pressure was normal. Oxygen saturation was 97%, and he was afebrile. Respirations were easy. Skin was warm and dry. Radial pulses were strong. There was no response to verbal stimuli, and he withdrew from painful stimuli. His eyelids fluttered on confrontation, and his eyes rolled back on passive eye opening. There was no incontinence, and a glucose chem strip measured 5.3 millimole per liter. There was no significant medical history. He was on no medications and had no allergies. In the emergency department, the patient became unresponsive to pain and had a Glasgow Coma Scale score of 3. Screening physical exam was normal. Blood tests including a CBC, glucose, electrolytes, and renal function were normal. Arterial blood gases were normal, as was urinalysis. The EKG revealed normal sinus rhythm initially, then sinus bradycardia. Urine toxicology was positive for cannabinoids. CT scan of the head was normal. The emergency physician's diagnosis was coma NYD, and the neurological consultation was requested. The consulting neurologist report noted that brushing the eyelashes elicited eyelash fluttering, and the patient resisted passive eye opening. When the patient's arm was held vertically above his head and dropped, the arm fell to the side instead of dropping to the face. Cold water caloric testing was performed with ice water irrigation of the auditory canal, producing a normal physiologic response of nystagmus to the opposite side, but no other reaction was visible from the patient. An EEG was considered by neurology, but felt to be unnecessary. The neurology diagnosis was psychogenic unresponsiveness, and the psychiatric consultation was sought. The patient was admitted to a medical ward for nursing care with IV fluids and the Foley catheter, with psychiatry assisting in management. Further history revealed then the patient had experienced a number of significant stressors over the previous 6 to 8 weeks. His family and girlfriend described him as a good kid, who was quite sensitive but was immature and tended to react in the moment. In the months prior, he had been pulled over by the police for speeding and did not have any insurance. Afterwards, he had not followed through with the local police office and knew the police had come to his parents' home looking for him. His long-standing tense relationship with his father, whom he worked for, was also worsening. He had recently been fighting with his girlfriend for 2 or 3 months. Then 2 days before his presentation in the emergency department, he and his roommates were given an eviction notice for unpaid rent. There was no history of psychiatric illness. The patient was drinking beer several nights per week and socially using cannabis. Regarding family psychiatric history, according to the parents, the patient's paternal uncle did the same thing about 20 years ago. The family was unaware if the patient knew about his uncle's history. The uncle had lost consciousness and was unresponsive for a few days. No etiology was ever identified, and the uncle's episode resolved with supportive care. On admission, the patient was started on intravenous lorazepam in addition to his supportive care. He remained unresponsive to painful stimuli, but was noted to occasionally move spontaneously in bed, turning over. On the second day, low-dose intravenous haloperidol was added. 48 hours after his initial presentation to the emergency department, the patient began to have intermittent periods of consciousness where he would open his eyes, could follow simple commands, and answer questions with nonverbal signals and limited verbal responses. Between these periods, he would revert back to his previous comatose state. By the evening of the third day, he could converse and stated he felt tired. By the morning of the fourth day, he was completely alert and had no complaints. He denied any recollection of the previous few days and last remembered going to his car with an intent to drive to a convenience store. A review for psychiatric symptoms was negative. Admissions to the psychiatric unit was not deemed necessary, and the patient was offered outpatient follow-up. He was discharged on the fourth day with no medication. So as we can see here in this second clinical case, we need to know the exact etiology because we just saw that the patient was discharged on the fourth day without any medication, which I found very interesting. I would like to thank you very much for your attention, and I hoped you enjoyed my presentation of the comatose state.
Thank you so much, Dr. Denis Danut. Is it okay if I ask you a few questions?
Yes, of course.
Okay, my first question is, what are the chances of waking up from a coma?
Well, when a patient begins to recover from a coma, they progress first to a minimal conscious or vegetative state, though these states can last anywhere from a few weeks to several years. Prognosis depends on a number of factors, as I said in my presentation. In one systematic review, the mortality rate varied from 25 to 87%. Non-traumatic unconscious patients presenting with a stroke, for example, have the highest mortality, while those presenting with epilepsy and poisoning have the best prognosis. A Swedish study of coma patients presenting to the emergency department found initial in-patient mortality to be 27%, rising to 39% at 1 year. So patients with a lower Glasgow coma scale at presentation with a score of 3 till 5 have a significantly higher mortality than those with a Glasgow Coma Scale of 7 till 10.
Okay, now another question arises to my mind is, what are the most important steps to do when a comatose patient arrives to the emergency department?
Well, the physicians are challenging to manage in a time-sensitive condition, so a systematic team approach is required. Early physiological stability and diagnosis are necessary to optimize the outcome. The 4 core components of care: history, examination, investigation, treatment, and management should occur in parallel. Also, a systematic and structured ABCDE approach should be employed by teams caring for unconscious patients. By that, I mean airway, breathing, circulation, disability, and exposure. And of course, supportive care and specific treatments must not be delayed. After the initial ABC assessment, the level of consciousness should be formally measured and documented using the Glasgow Coma Scale. So coma is defined as having a Glasgow Coma Scale under 8 or scoring U on the AVPU, which stands for alert, responsive to voice, responsive to pain, and unresponsive.
There's a public opinion about, like, they say that when you're in a coma, you can actually hear or feel something based on your research. Do you think that's possible?
Yes, when people are in comas, they are unconscious and cannot communicate with their environment. However, the brain of a coma patient may continue to work. So it might hear the sounds in the environment, like the footsteps of someone approaching or the voice of a person speaking. In fact, some studies suggest talking and touching a loved one while they are in coma may help them recover. With that also said, everyone who goes into a coma has a unique experience. Some have reported remembering certain events that happened while they were in the coma, while many others have reported not remembering much of anything while unconscious.
Okay, thank you so much, Dr. Danut. I want to thank once again all the ones who are involved in organizing this wonderful event. And I want to thank one more time Dr. Danut for participating in today's presentation. We are officially not live anymore.
Thank you very much.